Hey everybody, today's episode is a pretty powerful one. So, did you know that a child died because they couldn't read the referral letter that they were sent by the NHS? Well, that happened, and it happened relatively recently. So, a Romanian child was sent a letter, a referral letter for an MRI scan. The family couldn't read it though. They could read certain parts, so they could read the date, the time, they could understand that they needed to be there at that time, but the problem was that they hadn't done the right preparation. So I think it was around eating beforehand. So what happened was the child wasn't able to have that scan. They were sent away. They came back. They were sent away again. Same thing happened. And by the time the child got the scan, the results meant that the child was no longer able to receive treatment. They weren't going to make it. And unfortunately, the child died. Now, I'm sure you'll kind of see and understand and appreciate that's entirely preventable. And it's preventable with really simple technology. It's essentially just translating information into a different language and appreciating that it needed to be translated into a different language. Now, it's not a wildly high-tech solution that's needed, but a tech solution nonetheless can really help with that. And my guest today is Ghalib Khan. Now, I've known Ghalib for many years. He is an entrepreneur that has a very personal story behind why he's doing this. But he is translating information, healthcare information that's given to patients. He's translating that and making sure that it's given to patients in the right language, in the right way that's completely understandable. And in doing so, is changing hundreds of thousands of lives. So on the episode today, we talk about that story. We talk about Ghalib's personal story and how he has ended up being the entrepreneur that he is with the company that he has. And we talk about a few different things about patient experience as well and what's important and how we make sure this, hopefully, at some point, never happens again. So I hope you enjoy this one. So Ghalib, welcome to the Healthtech Podcast, mate. How are you doing?
Yeah, I'm very well, thanks, James. Thanks for the introduction. Thanks for having me on.
It's great to have you on. Obviously, this is incredibly sad for someone like me, like a general reader, but for someone like yourself, I imagine evokes a lot of different reactions because you know that it's solvable, right? So you tell me, man, what are you doing at Written Medicine and why is this article so relevant to what you are doing?
So first of all, it's a very low-tech problem. It's not even that high-tech of a problem to solve. You don't need AI or machine learning in these translation processes because a lot of the time, once you've done these translations, you keep them because these are standardized letters that you send out from the hospital. They're not going to be different for every patient, right? So some of the patients for an ultrasound scan may have to drink a couple of liters of water before coming. Some people may have to be nil by mouth in this case. And so it's very easy to provide and map. But the problem is in the NHS, you don't have you have ethnicity that's been coded, but it's from 2001. So it's 20 years old. They've probably got less than 10 ethnicities on there. But we've also been asking for country of origin to be coded. We've asked for languages, such as this case, to be coded, and also religion. And this is to help improve and personalize the care that patients get and improve their experience. What we do at Written Medicine is we provide accessible and bilingual medication content around the medication that's been prescribed and dispensed in the hospital or in the pharmacy. And we do this by not using AI and machine learning. We've got roughly a database of 3,500 directions of use phrases that you combine together to make a full direction of use. And then we put them through a 4-step language development process, utilizing 4 human beings who are experts in those languages with a clinician, particularly a pharmacist who is bilingual and will go away, test the combinations out over a number of weeks and come back to us and tell us whether something is changing or not. And typically, these are small changes that we would have to add. So sometimes there are certain languages that have multiple words for the same word, like tablet in Romanian. There's 4 words for tablet in Romanian, but there is no word for pessary in Romanian. So how do we then do that translation and make sure the patient's inserting the medication in the correct place? In this case, a lot of the hospitals actually do already have letters explaining to the patient the procedure that needs to be that will be taking place, and how they need to prepare for it. But because of that codification element not being there, they can't map the letters in the different languages to the particular patient. They would have to save it somewhere on their computer and keep on going to that file to retrieve it, and then send it as an email or as a text message, or by post to the patient. So it's a laborious multi-step process at the moment, which it doesn't need to be. And the report highlights this as well. It talks about ethnicity not being coded in the system, but we're also mentioned in the report as well, because we were interviewed by his for being a translation service and improving patient experience, even though it's nothing to do with patient letters at the moment. But we've also been approached by multiple organizations to help them with their letters and standardizing those letters processes.
So if you take what's happening right now, and I know this is certainly in the explanation that you just given, but I just want to make this incredibly clear. If you take what's happening right now, where we don't know, like I, as a say GP, I don't know whether my patient can read and write in English. Like I just don't. Even if they come to me speaking the Queen's English, the fact is, I don't actually know if they can read and write in English. And you can bet that if they can't, and even if they speak English incredibly well, they may well be too proud to say it, or don't want to say it, or whatever, and they're gonna take risks then, and we're taking a huge risk then in what we prescribe. Now, if you expand that into a GP seeing a patient for whom English is their second language, well, the chances of them now reading and writing in English is even less. And then for whom English is not only their second, but perhaps their third, and they don't speak it very well either, then obviously we're getting less and less and less here. Now, you tell me, like, for the GPs that are in those scenarios, and in fact, let's say the GP was actually able to talk to that patient in Hindi at that time by whatever chance that they could, and they had that discussion, they then write the prescription in a borough of London and send them away. Right? You tell me, like, what are the chances that patient actually gets that in Hindi? Is that 0% chance now? Like that actually comes back in? Like this problem must be enormous, and I'm just trying to sort of grasp it in my mind, like what the size of this problem is.
So secondary care and primary care have interpreting services, right?
Right.
But community pharmacy doesn't have access to it.
Right.
So we will typically a independent pharmacist, just say in East London, where he knows the main languages are Romanian, Polish, Punjabi, and Hindi, they will hire from those communities to reflect the languages. But that pharmacist typically won't know the ability of that person speaking those languages, because he's not just hiring them for the language services, also their competence to work in a pharmacy as well. So, but that's not been tested. So we don't know what's really being said. I can claim that I speak Urdu and Hindi as a second language, but when it comes to inserting suppositories or pessaries, I won't know the technical words for those, or the formal words for those processes. I will know the slang words, and that will create issues and embarrassment in the conversations and stuff. So typically, patients also will get shy from particular communities if a male pharmacy worker was to speak to them and they were female, and vice versa, about particular conditions and stuff. Another example is, just because an interpreter has been provided in the hospital and the medication was prescribed in the hospital, it doesn't mean the medication is going to be dispensed in the pharmacy or in the community pharmacy where we'll go the same day. So my son, he was seen in January, for example, by a dermatologist online, 10-minute consultation. We didn't get the medication until March. So
Wow.
whatever was said in that consultation in January, we're not going to remember 100% until March, and how to
Yeah.
apply these creams and so forth. And a lot of these creams, when we're getting them, it just says as directed on them. It doesn't say apply twice a day, blah, 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 for a particular area. And he's received multiple creams for multiple areas. So we had to write down during the consultation what those were going to be for.
Do you have estimates on the sort of size of this problem, either from, I suppose, the individual morbidity, mortality, or maybe like financial at systems level? Do you know the kind of scale of it from either of those perspectives?
So we know that typically ethnic minority communities tend to complain the least when it comes to services that they've received.
Right.
Right. As someone like Dr. Bola Owolabi just said last week, these communities are not the well-heeled or sharp-elbowed to know what they're doing and demanding the service that they need.
Right.
Sometimes errors do occur and deaths do occur, but the profession may not know about it. And one of these cases where is in a hospital in London, what I was told by a superintendent pharmacist, where they're providing outpatient pharmacy dispensary services in that area where the patient did pass away. But we know for a fact that mistakes happen on a daily basis. Patients just randomly sharing medicines and so forth, not knowing what those are. Typically, that could be even in an English-speaking community as well. But in an ethnic minority community, yeah, it's just like, oh, you haven't taken your blood pressure tablets? Oh, take mine. We can share ours and so forth. So, these typically do happen. And when it comes to costs, we spend 20 billion a year on pharmaceuticals throughout the whole NHS. Now, just say 10% of those medications are wasted. That's 2 billion a year that goes straight into the landfill. Now, we know ethnic minorities, particularly from the South Asian community, are 6 times more likely to be on long-term medication due to diabetes and cardiovascular diseases and high blood pressure problems. So these communities are more likely to be on long-term medication. And when we add the component of language into it and language barriers, there was a study done by Aston Medicine's adherence study where they found that 70% of these patients with language barriers were non-adherent to the medication.
70.
70%, yeah. So 70%. So, but in the general white population, it's 30 to 50%. In that community, in the heart of Birmingham, where the study was done, they looked at 6,000 GP records. By the way, so they didn't have to interview the patients and stuff. They just looked at their records, and they were seeing, in anomalies in the way they were taking the medication and stuff. And when they did do some small interviews with particular groups, they found that their language barriers existed. Even in our study, when we did our academic study with 152 patients, before we gave the intervention of a bilingual pharmacy label, 58% of the patients said they were taking the medications correctly or thought they were taking the medications correctly. When we gave them a pharmacy label in their own language, which is in English and another language, they over 62% of those patients discovered they'd been taking the medications incorrectly or not reading the warnings associated with it.
It's shocking, man. Honestly, it's shocking the scale of the problem, but seemingly I don't know, like how obvious the solution is. Can you? Well, there's another thing as well, actually, that I just want to mention here. That like there's adherence and the sort of morbidity, mortality end of this problem, which is like, here's all the bad stuff that can happen when this goes wrong. But there's also the other bit of like the patient experience, but also all of the benefits if this were to go extremely well and you really push those adherence numbers down, up, and the waste of medication down. Like, there's so much gain to be had on that side, and it seems that the solution is, well, certainly obvious, but I wonder what the barriers to this are now. So talk to me about written medicine, talk to me about what you guys are trying to do. and the challenge as to why this is not everywhere right now, because clearly it should be.
So there's two challenges in this. Challenge A is commercial viability understood by the system suppliers. They think they don't experience it. When they speak to commissioners and people, they don't experience it themselves. We're talking about people who don't interact with people with language barriers, right? So they're not in the same social class, friend circles, even professional colleagues and so forth. The only time they'd probably come across someone with language barriers is the cleaner that comes in the morning or in the evening, right? So that's about it. So that's one of the issues. And then integrating into the system suppliers. So we don't have open systems to go and integrate into your GP systems or your community pharmacy systems or your secondary care system. These are all closed systems and they're all commercially sensitive. They're all competing against each other, and they just, they've got bigger fish to fry financially. So this is not in that thing. And because of that, then that means I have to go and create a second system what people need to use just specifically for the bilingual medication information. But that means the workforce having to use two different systems, right? Just say, in a particular area, this is a 20% of the population problem with all your patients. That means for every fifth patient, you'd have to go and use on system. And that's not something that's really ideal. So we would like this to be integrated into the system suppliers and improving accessibility. So we're not just doing languages, we're improving the quality of English. So our core content has always been better quality English, and that content is codified. So it's linked just like the DM plus D is for medicine products in NHS Digital. Our content is all codified, and at the moment the English content is not codified. So a doctor's got a million ways of writing: take one tablet once daily, one every day, one OD, and so forth. Whereas we've standardized that so we can map to their content, and then it maps to the other languages as well. And we're also got pictograms for people with learning disabilities. So I'm quite privileged to have language barriers around my family. So it's not just a professional problem, but it's a personal problem at home as well. So I've got a son with Down syndrome. My mum speaks English as a second language. My grandmother is deaf and mute from birth. And I got dyslexia and dyspraxia as well. So I've got this whole mix of language and communication barriers. And when I go to my son's school, so he goes to a school that speech and language is the main priority, and everything on his wall is in illustrations and pictures, what they're having for lunch, where they go in the afternoon. Is it a library? Is it a museum? Is it a gallery? How they get in there? Is it a train or is it by the coach and so forth? And I thought when they leave, their educational organisations and come into the real world, there's nothing to support them. And all of these people I mentioned with communication barriers are more likely to have long-term conditions at a younger age. So people who speak English as a first language, but with a limited literacy or lower literacy, we know for a fact are going to be in lower income groups, and therefore probably on poorer diets and so forth, and are going to develop long-term conditions at a younger age. Ethnic minorities, as I mentioned, particular populations have particular conditions which up to 6 times more likely to develop at a younger age. People with learning disabilities, they're on medication from a very early age. So my son, he's not on any routine long-term medications, but he develops, upper tract infections, ear infections every winter, and he's on antibiotics for at least 2 or 3 months throughout, every year. Those creams and stuff like that. So we have to apply the creams to him. And then you're thinking about people, with Alzheimer's and dementias, they're not taking the medication properly as well. And in fact, there was a study done in a Liverpool hospital, where they found that 18% of the people attending A&E were because of adverse drug reactions. And this is because most of these were coming from care homes and people who were taking the medications themselves. But because the medication boxes are changing all the time, they don't know what they're taking themselves.
Yes, absolutely wild. I'll say it again, the scale of this problem. Just give me an example of somewhere where you are using written medicine, or a hospital, an area, or somewhere that is using written medicine, and just tell me some of the experiences that they have had using written medicine to solve this problem.
Yeah, absolutely. And, it's been so London North West Healthcare, which is Ealing Hospital, Norfolk Park and Central Middlesex, they were our first customers. They've been using written medicine, soon to launch a new version of written medicine there as well, in that patch. And it's been mixed because patients want it. They can't give it to all the patients. They started utilizing it with 2 patients a day. So that was where they would start from. Then one day, the chief executive came through and they showed them the innovations that they're using. And they were like, wow, this is amazing. We need to do some more local publicity and so forth. And the only challenging element from there is that it's available in hospital, but it's not available in the community pharmacies. And this is something that we are now tackling by the ICBs, because before, NHS England had the contract for community pharmacies, not the CCGs. But if you went to NHS England's pharmacy team, they would always say, well, it's not our problem. This is a regional problem, Ghalib. You should go and speak to the CCGs. When we speak to the CCGs, they would say, oh, it's not our problem. You speak to NHS England. They're the contract holders for pharmacy. Yeah. And but now we've just recently been procured across the whole of West Yorkshire ICB to do the exact same thing, where it's available in the hospitals and in the community pharmacies. But we're still going to be faced by that problem where it's a non-integrated product. We're not the barriers here. We can integrate. We've been funded by NHSX to do FHIR integration, FHIR. We've got our, there's various different ways. We've integrated into an e-discharge system at Ealing Hospital, which was then taken over across the whole London North West Healthcare. They're now getting rid of that, and they want us to integrate into Cerner. So it's the payers. We can't go to the system suppliers and say integrate with us, because we are a third-party organisation with no commercial interest with them. But it's the customers who are utilising our software. They're the ones that has to go to the system suppliers and say, guys, what are you guys doing? Because it also, the CQC can come in, or the General Pharmaceutical Council can come in and do an inspection. And they're now asking, like in Leicester, in London, you serve a diverse population. Show us how you're making your services more diverse.
Yeah. It's awesome work that what you're doing, man. And as I say, the scale of this problem is so large. The solution to this system, or the solution to this problem, is so clear. But how many times have I said this on this podcast recently, that the things that excite me at the moment are the infrastructure changes? This is another example, and now we're talking about interoperability, but this is another example of a deep infrastructure change that would enable all of this innovation. Because let's be clear, when you're going to shift from one program to another, probably 50% drop off right there, easy. Like in a snap, 50% of people are no longer going to do it now, and probably that's higher, to be perfectly frank. I don't know what the actual numbers are on that, but as soon as you have to go to another program, your ability to get adoption, which is difficult anyway, we know this, is just going to drop off immediately. And here again is another example of a deep infrastructure change that will solve at least that problem, make it easy, get the integration, and then all of a sudden it's integrated, it's bought, it's integrated, it's used a lot, and then the benefits are going to be more clear to the buyer. And the most important thing is that those benefits are going to get to those patients, all those patients that are currently not adhering, that are currently taking medication wrong, that aren't getting it right, that through no fault of their own cannot understand the instructions given to them. And to just go back to this article to finish off, how many more of these articles do I have to read before something is done? And actually that frightens me a little bit, because, you know, the HSIB or HSIB, I think you called it, Ghalib, like, they've done this investigation, they've made their recommendations. What next? And yeah, I just wonder. I hope there are some decision makers listening. I hope there are some people that listen to this podcast that can actually make a difference to this, because I think this is such an important cause that affects so many people and has such a massive ability for impact. And so, Ghalib, I know it's been a short episode, but thank you so much for coming on, mate. I really appreciate it. It's so important to shine a light on this, and I wish you all the best with everything that you're up to, buddy.
No, thank you very much, James. And hopefully I can come and give you some more updates in West Yorkshire. It'd be really interesting to see how the adoption goes over there. Just because the licenses have been procured, it doesn't mean people want to use it. That sometimes NHS trusts have their roadmaps. You know, this is our digital roadmap, Ghalib, for the next 18 months. Can you come back in 18 months? And I'd like to see how we can influence adoptions into the roadmap of products that are resolving health inequalities. Because I don't think there's any digital product on the market that looks at BAME health inequalities and stuff. And I think we were the first people to do this, but it's still a struggle.